much. Good afternoon, everybody, and I really appreciate all of you to be here. Thank you for this wonderful opportunity. I was just wondering how these two gentle giants have been awarded today the Lifetime Achievement Award. I really respect and admire and get inspired, especially Dr. Desai, Dr. Iyer. It has been an unbelievable journey that I have witnessed. And Jayesh, your presence merely matters to me. Of course, Ameya, I don't know whether he's here. But thanks for all of those wonderful moments that I had. That is always one of the favorite grounds. So Vinit, thank you very much. And Anamika, thank you very much. And entire Virar, thank you very much. Today, next 15 minutes, I was told that I'm supposed to talk on the rational use of antibiotics. Do I have to really talk about it? Do I have really? Anyway, this is what my wife, she's sitting right here, and I smartly replaced that word as doctor, but she wanted to say it as a physician. Though it is a voluntary statement, but she always, says this to me. Do you know, Mangesh, that physicians or the doctors are the people who prescribe medicines of which they know little, to cure the disease which they know less, in human beings of whom they know nothing. I was really upset. Anesthesia, they do not waste opportunities to insult, But then, when I looked at the definition of what she wanted to say, when I started preparing for this talk, and when I saw what is there likely to be served on our platters if we do not do the things right, and I know Vinay is there, he definitely agrees to me, that this is the challenge that we have to be prepared for. What is called as the antimicrobial resistance. So friends, let us have a discussion and debate today on the rational antibiotic use, especially in the OPD practice. These are my disclosures. Let me tell you that I am very proud that ICMR has done a pivotal work as far as the antibiotic stewardship. And of course, a few other pointers are from the WHO guidelines. I will be keeping away from all these things. The time will stop me. But how many of you are aware that out of almost 100 trillion cells, 90% are occupied by the lungs? Hi, Amit. Please stop. Thousands of species, they grow, they produce, they reproduce, they evolve in us. 90% believe that they are not pathogenic and they are all protective bugs. But you will be surprised when I say that if you really isolate them and weigh them, they will weigh nearly 1.5 to 2 kgs. That is what our antimicrobial flora is. This is the first paper which got published when Alexander Fleming here in London, along with his team, who actually commercialized the first antibiotics, and this happened during the Second World War, where Edwin Chan and Florey, along with Fleming, made this super success of the first available antibiotic for the human use was 27. This is the place. These are the pictures that I shot while I was in London. This is at the Westminster. On the second floor, there is still a plaque on the name of Professor Sir Dr. Alexander Fleming, and we know that this was an accidental discovery. But there is noble lecture which he delivered in 1945. He talked about this, which made a sense that it is most difficult to keep organisms away from developing resistance. And look at the last 4 lines. That if somebody goes to a pharmacological store or a medical store and purchases and use this antibiotics in an underuse, in a wrong way, it's very easy for the bugs to develop resistance. I really appreciate the lay press. Look at this Times of India article which surfaced in December 2014, but I still have it in my collection, which talked about the last antibiotic resistance or sensitive bug is surfacing in India. And you are talking about the MDML virus, that is New Delhi metallovirus that we had, metallobacteria that we had. This is 2022. You can see Mint writing down about the antibiotic resistance. This is Independent writing down the antibiotic resistance. This is a UN site which mentions about the threat of antibiotic resistance. Believe me, if we do not practice antimicrobial stewardship, you are looking down the barrel of nearly 5 million deaths annually just because of non-availability of the antibiotics by the end of 2050, which is far more than a nuclear explosion as well. Look at the antimicrobial death threat that we have. Look at the projections, look at the amount of the money that is going to be required. $100 trillion are expected. Why? Because look at the antibiotic use that has gone up in India. This is WHO CDI data that I am publishing, I am showing. At the end of 2000, look at the prescriptions of antibiotics. And now look at 2050, nearly doubled in 15 years. We have started doing it regularly on the regular basis. COVID saw the most outburst of the irrational use of antibiotics. And that has led to non-prescriptional antibiotic supplementation at every possible level. How much antibiotic we use? 22,000 tons of antibiotic we use annually. 11,000 for the human use, but what is most concerning are the last 4. 50% are used in the animal industry or animal husbandries. That is the place from where we actually start kicking off with this antimicrobial resistance. And look at the commonest bugs. If you visit the ICMR site, they have told you that the commonest bugs that you encounter are E. coli, Klebsiella, Proteus, Acinetobacter. That's all. That's all you are supposed to know when you are practicing in the OPD. But look at the antimicrobial resistance that has been reported. This was E. coli, this is Pseudomonas, this is Klebsiella, this is Acinetobacter. India stands there. And look at the trends. I was really concerned when I saw this polymyxin B resistance rise in the last 3 or 4 years of time. What will be left out with if we really start doing, the irrational use of antibiotics or using these antibiotics irrationally? Klebsiella, E. coli, Proteus, Pseudomonas, Acinetobacter, everybody, all practicing physicians, doctors should be worried about. Surgeons, orthopedicians, gynecologists who are in the crowd would really agree that this is the area where we need to change and improve. So why we use antibiotics? Definitely for the therapeutic purposes, as a prophylaxis, and sometimes empirically. And unfortunately, majority of the times we end up using them in empirical therapies. Nearly 85% of antibiotic prescriptions are just empirical. And we do not have patience to hold on. This is the brutal truth. And we start with the irrational combinations right from the day one of the patient entering in your OPD. Direct targeted therapies are very, very few, and very few practice that sincerely. So I just wonder why we use that so empirically. You are definitely allowed to use it if there is a life-threatening infection, if there is a limb-threatening infection. Patient has sepsis and you have not started antibiotic, is likely to lose or cause a problem, like febrile neutropenia, yes. But then remember that the moment the next report or a culture pointing out the bug is available, you should be prepared to change or de-escalate the therapy equally rapidly. Unfortunately, we do not grow well. The cultures are not asked for, and whatever the cultures are sent to us, lot of times we end up getting from the pathology laboratory that was culture to negative. Now that is the place where you start antibiotics. But the biggest cause is the provider's belief. Fear of missing something or error, not believing on the culture data. We always formally believe that that secondary bacterial infections are always present when you get a simple viral sore throat. Patients are likely to be sick, so they require more antibiotics or a combination therapy. There are now litigation fears that we have, fear of losing the patients that we have. And not only that, there is a peer pressure from the Googled patients. So Google and WhatsApp universities will pressurize you through the patients or the relatives. Somebody sitting in the United States gives you a call. That's a this, that, this. So in India, 50% of the antimicrobial prescriptions are incorrect in what ways? In an indication, in a choice, in a dose, in a duration, and the route of administration. And the vicious cycle continues. Inappropriate antibiotic use will worsen the resistance. The resistance will cause the failure of treatment. Failure of treatment will further make you to push through the inappropriate use of the antibiotics. So these are all the factors that we discussed. Friends, remember that this is a limited resource. Use wisely, because if you really look at the entire development of the antibiotics that we have, and I would like to draw your attention to last decade, only 3. If you read the names, Vidacolin is only available to the government hospitals. We are not supposed to get that. So what we have, there are no new molecular entities or entries which are happening as far as antimicrobials are concerned. So the pipeline is getting dry faster. This is what I was talking about. This is 2004 data. You will say, sir, this is old data. But look at the anti-infective entries and antibacterials. But then this is the new data that I have. 2022 data, which is there on the WHO CDC website. Look at the number of the antibiotics there in the research. Look at 2021, the far left of your slide. Only 2. So there is no research happening. And the worst is that even before you have used the antibiotic, the microbes have developed the resistance, and this is reported. Look at the first, penicillin. Available for the public use, 1943. The first resistor was reported in 1940. Look at linezolid, 1999. We had a first resistance where it was allowed to be used in 2000. Now that is the brutal reality of the fact that we need. And that is the reason why what Shilpa always told me, that whenever man comes out with a better mouse trap, nature seems to have a better mouse. This has led to the area of bad bugs and absolutely no drugs. And this is the place where we have to be concerned about. Had it been a conference like this of the bacteria, a speaker like me speaking to the friends, that we are the next gen drug-resistant bacteria. As the humans continue to use and abuse and overuse antibiotics, our ranks will swell. So go out there and mutate, and remember that which does not kill you will make you more mightier. So friends, for me, antibiotics is a unique group of the drug which is licensed to kill. Remember that. These are the drugs which are licensed to kill, but unfortunately destructive when they are overused. They do have a personal and a wide social impact, and yet unfortunately we do not recognize it. And believe me, this is the truth of life, that the only group of the drugs that you use erroneously will have an impact on somebody else's life, somebody is close to you. That is most important. So last 5 minutes, how would you tackle it? How would you manage it? So let's check out what common OPD infections that you see, quickly. What common infections that you see? Now these are all the infections that you see. But if you really look at it in a very smart way, like Jess is occupying IMA and the entire business of IMA. I look at API, and Shilpa looks at ISA. Vinita and all these people, they look into the local IMAs. So similarly, bugs also occupy the system very smartly. Then look at the upper respiratory tract and the lower respiratory tract. They are mostly occupied by the gram-positive bugs. Now why I am saying this, you should choose your antibiotics whenever you are necessarily using it regarding the possible likely organisms. If you look at the abdomen, urinary tract, the meninges or the central nervous system, the commonest bugs are gram-negative. So choose antibiotic wisely. When it comes to mouth and skin and soft tissues, probably anaerobes and the atypicals will grow. And we all know about our armamentarium. These are penicillins. These are the mainstream drugs. We have cephalosporins, all generations of cephalosporins. Now, who will tell me what is the difference between the, I would say, antibiotic spectrum of a first generation cephalosporin versus a fourth generation cephalosporin? What is the difference? As the generation, I know some you will be aware definitely, as the generations will progress, first generation cephalosporins are primarily the gram-positive killers and very, very minuscule gram-negative activity. So they are good drugs for the respiratory tracts. They are good drugs for the skin and soft tissue infections. Right? As the generations of the cephalosporins go ahead, the gram-positive activity will start going down, the gram-negative activity will start coming up, and then anaerobes, pseudomonas, ESBL bugs will start coming into the picture. Macrolides are bacteriostatic and they have a role to play. Most macrolides are bacteriostatics. Quinolones I will cover just in a minute in subsequent slides. And then we do have aminoglycosides, but unfortunately, I'm really upset to say that this is what the big guns are. And we use them so freely and frankly. We do not use them with inhibition. We just use them without any thought process behind it, without even knowing the cultures. If you look at the honest choice of the antibiotics, when it comes to upper respiratory tract, the best choices are macrolides and penicillins, and maybe first generation cephalosporins. Doxycycline becomes a good addition. When it comes to urinary tract, choose a gram-negative bug. So newer generation penicillins, fluoroquinolones keep out. Now the reason why they have to be kept out in your OPD practice, I will be talking to you. Third and fourth generation cephalosporins and aminoglycosides. When it comes to abdominal infections, and Dr. Iyer is here, you realize that cephalosporins, they become the brilliant choice of the therapies. When it comes to lower respiratory tract infection, again primarily the gram-positive drugs. Mouth and soft tissue and skin infections, along with the antibiotics, you should choose a drug which should have an anaerobe cover. Right? Why I am talking about fluoroquinolones not to be used in your day-to-day clinical practice? Because, friends, we are in an era of multi-drug resistant tuberculosis. And our pulmonologist friends only have one armamentarium left which is very effective, are fluoroquinolones. And look at the fluoroquinolone resistance reported in India. Look at all the bugs. Now these are E. coli, 71%. This is the Pseudomonas, 34%. This is Klebsiella, 61%. This is Salmonella typhi. We use ciprofloxacin so freely, 37%. So how do you choose, finally, an antibiotic on the OPD practice? Always look at the site of the infection, suspect the organism, community versus hospital-based acquired infection, assess the patient, check the host immune status, and also find out the associated comorbid conditions. Remember that there has to be no antibiotics for viral infections. Please do not use them at all. Please, for heaven's sake. Try and establish the site of infection. Consider the empirical broad spectrum only when it is necessary, as we have discussed. But most importantly, de-escalate the therapy if you feel that you have started a wrong antibiotic, or probably the culture reports have shown something else. And understand, always consider the host factors. Use the correct duration, and this is the chart of the ICMR approved 2022 drug duration therapies for different areas. Please stick to the guidelines. Always be watchful in all these patients, those who have got these conditions, especially splenectomies, on chemotherapies, on malignancies. Remember that there is nothing like universally good antibiotic. Why I say so? That because if you look at the ideal antibiotic from according to our views, what should be an ideal antibiotic? ideal antibiotic should satisfy all these parameters. Do you feel that even the newer antibiotics will satisfy all these parameters? I am sorry to say this, sir, that this is not possible. Finally, a silver line to the grey cloud. There is some research which is happening. We are looking at the phage therapies. One of the very promising things is antimicrobial peptides and lipopeptides, which will absolutely next 2 minutes I will be finishing off. Impossible for the bugs to develop the drug resistance because they have to entirely change the cell wall. But then this research is in infancy. I don't see that our generation at least will be able to say this. So currently, my message to you is follow the guidelines. But remember that guidelines will only work if we practice them. Otherwise, there is no use. WHO, ICMR has taken a step, but there are still gaps. So, the community solution, not only at the individual level, but at the every possible level, has to be done. And who are the stakeholders? All these are the stakeholders. These are all the people, those who are responsible for the antimicrobial stewardship. So, whenever there is a pathogen, there is an infection. There is an infection, there is an antimicrobial use. There is an antimicrobial use, there is a resistance. There is a resistance, there is an antimicrobial resistant pathogen. So, to stop this, we need to intervene at all these 4 places to have a susceptible infection. When I was learning from Jayesh, he has reminded me of this line, the history of medicine. 2000 BC, eat this root. 1000 AD, this root is healer, say this prayer. 1850 AD, this prayer is a superstition, drink this potion. 1920 AD, this potion is a snake oil, swallow this pill. 1945, first antibiotic, take this. The pill is ineffective, take penicillin. 1955, oops, the bugs are mutated, take more stronger antibiotic. Between 60 to 2020, 39 more oops. 2035 and beyond, the bugs are one. Eat this root. So this is Bill Gates talking about the biggest threat to humans in the coming times. In his TED talk, is it this? No. This is the threat that we are going to get. Look at the paradox of life. Globally, per head, we spend 17,000 per person per annum in protecting our borders. If we just invest, an investment person Dr. Agarwal was here, 143 rupees per person per annum, that would really help us in protecting mankind. So if at all I have to really put in the entire evolution of life on a clock, you will see that humans have the bugs have been born at around 4 o'clock. Humans are born at around 11:58, 43. Why I am showing this is just to make you realize that we cannot chase the bugs. We must stop creating the unnecessary pressure by doing this. And this is for Dr. Desai. He loves to write poems. This is what I wrote in the morning when I was preparing this on the antimicrobial resistance. A silent threat, a mounting dread, antimicrobial resistance, a bothersome spread. Infections linger hard to heal, fate we face, a losing deal. Antibiotics, once a seal against the infection, still a potent deal. Now overuse, reckless thrill, begets resistant strain and a hefty hospital bill. Misuse the drug, which is a magic kill, and the bugs will find the way in a cunning skill. The microbes evolve, the biggest ordeal, the biggest tension, the biggest thrill. Leaving us sick, the money we spill. So friends, listen to close. This is the deal. Antimicrobial stewardship is the only way to heal. Use them right when you are truly ill. for the healthier, happier futures with the doctor's way. So let us pledge on this IMA platform, as we pledge to invest rightly, as we pledge to practice rightly. Let us all pledge today that we will not misuse antibiotics and we will promote the antimicrobial stewardship at all the possible levels. Thank you very much for the questions.